And welcome back from the break. I hope you had the opportunity to get up and perhaps away from your desk or laptop and stretch a little bit. And we are back with our clinician roundtable. So new to our symposia series this year is an annual spotlight on the medical advancements for a particular tumor type. We will address a different disease site each year as we move forward with the symposia series. But for this very first spotlight, we've chosen to focus on the advancements in the management of lung cancer, the tumor type which accounts for the highest incidence and mortality in Canada. As precision oncology continues to evolve, lung cancer has become a leading example of how targeted therapies are transforming cancer care. The integration of comprehensive genomic profiling has redefined treatment strategies, enabling clinicians to tailor therapies based on tumor-specific biomarkers, improve patient outcomes, and minimize unnecessary toxicity. This clinician roundtable will explore the latest therapeutic developments in lung cancer across systemic, surgical, and localized therapies, highlighting evolving standards of care and looking towards the future. We are joined by Dr. Kevin Zhao, who is a medical oncologist in Montreal and a medical advisory committee member with Lung Cancer Canada. Dr. Zhao is kindly moderating this roundtable discussion. Stage 4 EGFR mutant lung cancer survivor and patient advocate Yuan Liu will share her experience and perspectives with us. Welcome to our two medical oncology experts, Dr. Stephanie Snow from the QE2 in Halifax and Dr. Shakil Kassam from the Stronach Regional Cancer Centre in Ontario. Dr. Marcelo Saipel, thoracic and lung transplant surgeon and surgical director at the University Health Network, joins us on this panel as well. And welcome to Dr. Srini Raman, radiation oncologist with BC Cancer in Vancouver, and Dr. Elizabeth David, interventional radiologist at Sunnybrook Health Sciences Centre. So a very warm welcome to all of our panelists. And without further ado, I'll turn it over to you, Dr. Zhao.
Thank you, Cassandra. And first and foremost, I really do want to thank CRAN for the wonderful organization of the symposium, but two, for inviting us to talk about lung cancer. It's something that we appreciate fully, and giving us the platform to talk about where we're at and where we're going. And I think we have assembled an outstanding panel to talk about everything that's going positively in lung cancer, but as well as some of the challenges I think that we're facing that's real and impacting our daily practice, and particularly in terms of patients. So I want to thank everyone who's attending and listening to this panel discussion. I hope that you will have tons of questions and obviously gain a better light of where we're at in lung cancer. And I just wanted to start off by saying a few things in terms of why this panel session was important. I think Cassandra sort of mentioned that lung cancer, unfortunately, and the statistics from the Canadian Cancer Society this year still highlights the biggest problem is that lung cancer remains Canada's #1 diagnosed lung cancer, and unfortunately it is the #1 cause of cancer death in Canada. And I think it's a big issue for which there are many problems that we need to solve. But certainly, I think if we are to sort of advance survival, I think some of the things that we're going to discuss today are going to address that. But I think one of the biggest things that we can take away from as a positive, and that also is borne out in some of the statistics that came out this year from the Canadian statistics, is that we've improved survival. And if you look at how survival was in 1990, the 5-year survival rate was around 13%, and the latest data shows that we're up to 27%. And that's not including anything that we are going to talk about today in terms of the advancements in lung cancer and some of the advancements in terms of our procedures and other therapeutics that we're able to offer patients. And I can't think of any other better example of some of the advancements than our first panelist, who will remain in the black because she has a problem with vertigo today, but Yuan, who's a patient with lung cancer, but is now benefiting from some of the therapies that we're able to offer today. So Yuan, I'm going to throw this to you to start off with. How are you doing?
Thank you so much. I apologize in advance that I'm not on video. I'm rather self-conscious thanks no thanks to treatment side effects here, so I'm off camera. I want to thank everybody for having me, and especially the Robbie Spring, who's part of the organizing committee, for thinking of me and inviting me to do this. As someone diagnosed before the age of 50, and now I have no choice but to not work because of my disease. I feel like advocacy gives me a sense of purpose and focus, and I really thank that you've thought of me and have me participate in this today. So I was 48 years old when I was diagnosed with EGFR positive stage 4B lung cancer with innumerable, air quotes, mets in my lungs, in my bones, and in my pleura, also caused rib fractures and 5 brain mets. Like many women my age, I didn't spend a lot of time thinking about cancer when the symptoms start propping up, especially since I have almost no family history of it. One cousin had breast cancer. That was about it. I was busy as a member of the sandwich generation. This was 2022, and I wasn't really paying attention to the symptoms. Working in 2022 was pretty stressful. I was a project manager. We had tons of deadlines. So I was trying to make working remotely, working partially remotely, work with the demands of everything else that was going on in my life. There was back pain, which I sought the help of a physiotherapist because I thought I twisted a muscle or something like that. There was fatigue and breathlessness, which I blamed on aging and having a busy life. My doctor prescribed inhalers, called it allergies, and none of it helped. It was actually a routine cardiology exam for my hypertension that revealed that half of my lung was collapsed. When the cardiologist explained that to me, he said, "Do you know what a pleural effusion is?" A light went on inside of me, and I remember saying to the doctor, "This explains how I've been feeling." Like, light went off. This set off many more appointments to treat my symptoms and diagnostic tests. I was very lucky to have a proactive team who knew what to do with scans and biomarker testing. They didn't do sequential testing. They just scheduled everything. Let's do a brain MRI. Let's do a CT scan. Let's do this. And even my GP had a bit of time trying to catch up with it because it was actually the pulmonologist was very proactive in doing all of these scans. My GP ordered a chest scan, and the pulmonologist expanded it to a chest and abdomen scan. He kept saying, I don't want bad news or the extent of your tumors or your cancer be a surprise for you. Like, I want to do all of it right now. As someone trained in science, who at one time I did DNA sequencing manually, I wasn't aware of the advances in cancer biomarker testing or precision medicine, even though I worked in biotechnology. So I got into that world pretty quickly. When we found out about my mutations a few weeks later, we started on osimertinib or Tagrisso. 3 years ago, that was standard of care, and it was very much a chemo-free approach that oncologists emphasized on. If you're diagnosed now to the most common EGFR mutations, you have options that we didn't have back 3 years ago. These options now offer far more superior overall survival statistics than standard monotherapy that I was on. This is definitely something I would encourage all of you to discuss with your doctors. Your current treatments, what is next, map out the scenario, and the options that are available to you. So I had a little over 2 years of Tagrisso honeymoon. I didn't need any other treatments, such as radiation. The pleural effusion that collapsed my lung cleared up within weeks. I was feeling much better within months. From a devastating prognosis of innumerable Mets and taking steps to settle my affairs, I made my will, I made my power of attorney, and all that. I started to see a life with cancer. My palliative care doctor was the first one to suggest rehab strategies to regain strength and lung function. This is another thing. You gotta get palliative care doctors on your team because it's not all about end of life care. It is about quality of life care. So I started a few cancer exercise programs and I've kept up with that ever since. So this has been great. Unfortunately for many of us, in February 2025, earlier this year, the cancer did progress and it did find new resistance mutations that dodged osimertinib. So my honeymoon with a pill a day ended and I'm on second line treatment. I'm not so lucky this time around with side effects and have been working hard with my doctors to manage side effects of systemic treatment and radiation treatment. Thankfully, it is stable for now. I just had scans. At this point, I do want to add a side note though, on the time toxicity of my treatments currently. In Ontario, chemo is covered in the hospital by a OHIP, but my other combination drug, amivantamab, is not covered. And I have to divide my infusions to 2 trips on 2 different days to 2 different locations every 3 weeks. This puts burden on myself and caregivers, especially those of us who are still employed. I have heard of hospitals covering the second drug, but I suspect that is because it is covered for the over 65 through the Ontario Drug Benefit Plan. So this is something to think about when you have early age onset cancer. I am very privileged to have a progressive medical oncology team, though, where each line of treatment is biomarker informed. This approach currently has challenges, including reimbursements, and it's something we patients unfortunately need to advocate for. We shouldn't have to. Having cancer is hard enough. As young ones, we do have age on our side. I would emphasize that we should be protecting our baseline health, including getting all the other cancer screens that you're eligible for, because cancer doesn't just hit once, it could hit twice or more times than that. So that's something that we should be keeping an eye out on. Keeping our baseline health is important because it helps us tolerate the challenges of treatments and its side effects. COVID is not over, and it causes long COVIDs, hospitalizations, and deaths. These setbacks, like infections and delayed treatments, or worse, cause acute and or chronic outcomes such as long COVID. My radiology reports on more than one occasion have still innumerable lesions. They just stop counting. That is very crushing to hear. But I'm here to say that there remains hope. Science is good. We have more treatments now, even in second line and post-first line. We have much more options in treatments than we did 2 years ago. And we see more and more data now and more clinical trials. So hang in there.
Well, first, if I may, and I just want to say first, everything you just said sort of outlines everything that we're going to talk about. So that's why I thought it was particularly important that you get us off started. Thank you so much for that. It's a really powerful message, and it illustrates something that I forgot to mention at the beginning of the fact that, you know, we talk about lung cancer as being a very old disease, but in fact, the face of lung cancer is changing dramatically, and I think you represent every aspect of that. And everything that you've mentioned in terms of genomic profiling, but just the type of patient you are. We've traditionally had this image of, you know, elderly patients who smoked all their lives getting lung cancer, but we realize that is no longer the case. And just so people who don't know, you know, 20% of our patients with lung cancer have never smoked, have never touched a cigarette in their lives, and we're working out why. There are various theories, but the reality is this. It's not patients who smoke who get lung cancer, it's anybody. It's your brothers, it's your parents, it's your kids. And we have this little saying at LCC that really the biggest risk factor for lung cancer is having lungs, and that is true, and that's UN's story just proved that to us. So thank you for that story. We'll get back to you. I wanted to just sort of segue. I think it segues almost perfectly to Dr. Kissam, where I wanted to ask you, and I think listen to that story. I think it just shows really importance of where we're at in terms of understanding lung cancer. And I think genomic profiling and molecular testing has become almost quintessential in being able to treat patients with lung cancer now. So I think, you weren't a resident yesterday. You've been doing this for a while. Over the last few years, how have you seen the advancements of lung cancer and everything that we're doing impact patients like you, Anne?
I think it's a really good point, right? How much things have changed in terms of being able to get biomarkers for our patients in a timely way has dramatically improved, over the last several years, right? 5 or 6 years ago, as you would know, Dr. Zhao, is that we were just checking single genes on PCR. So we would get ALK, EGFR, and maybe PD-L1. And now we are doing next generation sequencing on tissue where we're getting a plethora of biomarkers on genes all at the same time and all within about 2 weeks, 2 to 3 to 4 weeks, depending on where we are. So it has changed dramatically. And I think in addition, not only just the ability to get NGS, it is now more broadly available. And when NGS and biomarker started, I think it was very much, isolated to the academic centers in the surrounding regions. But if you were up in the northern parts of Ontario or in northern parts of Canada, that would almost be prohibitive just in terms of getting these things. And because of the way things are turned around so quickly and how efficient we are at getting samples in and run, we're getting more and more biomarker information quickly. So I think not only the turnaround time, but then also once we identify new biomarkers, developing treatments for it. And to UN's point about getting second-line therapy that we didn't even have available, a couple of years ago is because we found a biomarker for which there was first-line therapy. And then we were all like, oh, now we need a second line. So it's changed dramatically in terms of cost, turnaround times, and access throughout Canada, I think.
So I guess, and you've probably seen this in your clinic almost daily, when we have patients coming in to us, and regardless of age, and I think the one thing that we start to notice really is in our younger patients as well, coming in with lung cancer. But I think the image of what they expect when they see us for the first time is relatively the same, right? They think they're going to get toxic chemotherapy, they're going to lose their hair, they're going to throw up all the time, they're going to have suffering for what benefit? Because, there's stories and images of patients with lung cancer and they don't look pretty. But when you come in and you explain to them everything that goes into now diagnosing lung cancer, whether it's localized or advanced, what message do you transmit to them when you talk about, for instance, the biomarkers that are now important in terms of how we treat them?
I think to your point, that my most dreaded consultation is with a young patient with lung cancer whose biomarkers aren't available, and I think the reason that is because if they are highly symptomatic, if they are unwell, their only immediate treatment option available to them is systemic chemotherapy, and, it's not bad. It's not, there's better treatments that we have, but that's my worst feeling. And the reason being is because if we know that a patient has a biomarker, if we have those readily available, we can counsel them on treatments that both prolong their quantity of life and quality of life relative to the standard of care before targetable therapies. And to UN's story of osimertinib for 2 years, about the median PFS on that drug, the comparator arm to that was chemo. And so that study did confirm that osimertinib in the first line is better tolerated and makes you live longer. And that's essentially the discussions that I have with my patients, as you do, as Dr. Snow does, is that when we have a targetable mutation, having that information allows us to have a conversation about tolerable treatment options. And yes, we may need to intensify in certain situations, but at least we have that backbone of a tolerable drug thanks to the NGS or the biomarkers that we have on hand.
Right, thanks. So I'm now going to segue, because I mean, obviously, talking about NGS, talking about all these drugs, and I think you'd agree with me, Dr. Kassam, that I think lung cancer has been the model in terms of really understanding the biology of lung cancer. Now that lung cancer is not one disease, it's multiple, right? So having all these new targets is quite exciting for us as oncologists who don't have to just prescribe chemotherapy anymore, but it's also pretty much really key to treating our patients.
Totally. I think, when molecular tests or biomarkers first came out, at every talk that I would go to, and listen to speakers like yourselves, and they would show that pie chart, where you've got lung cancer, and then it shows how many are biomarker driven and how many were not. And about 6-7 years ago, it was 30% we have biomarkers for, and there's the 70% that is unknown, that purple area, the nebulous purple. And over the years, that sort of unknown part of that pie chart has gotten smaller and smaller and smaller. And now it's the reverse, right? The unknown biomarker driven lung cancers are about 30%. And we know that there is some kind of driver, whether we can or cannot target it, but we know that there's a driver there. And now the question is to get drugs to target those targets.
And we can only hope that this could apply to all cancers. That would be my dream, actually. So Dr. Snow, Dr. Kassam has elegantly just pointed out some of the exciting stuff that's going on with biomarker directed therapies, NGS, but we've been at this for a while in terms of fighting. I wouldn't say fighting. I think we've been advocating for not just lung cancer, but for many sites, getting access for all patients, but it comes at a cost, right? That's the biggest issue. That's been the biggest barrier, I would say, from a public payer standpoint. I guess for those who don't know or not involved in lung cancer or cancers in general, or not a patient, the general public taxpayers would say, is it worth it? Is it something that's necessary to invest millions and millions of dollars in all this? And yet we hear stories like Yuan's, who this is the reason we do it, right? Like, in your experience, like being an advocate for lung cancer, among other things, like how has your perspective of cost been sort of driving how you think about things?
So I think that's a great question, Kevin. And I think that I'd like to start off by talking about some work that CRAN was actually instrumental in developing with the biomarker tumor agnostic conference this spring. And we looked at the value that comprehensive genomic profiling brings to some of our major cancers, for including lung cancer. And in many ways, lung cancer has led the way for solid tumors for the introduction of targeted therapies and therapies that are informed by our molecular results. And that was really astounding to see that translated into life years gained and dollars actually saved from a societal perspective. And there's no doubt about it, comprehensive genomic profile in lung cancer leads to thousands of extra life years gained, and like an astronomical amount of money that's saved. Because when you think about it, if we can have people who are healthy, who are feeling well, and are ultimately more likely to be cured, because we just don't use these targeted therapies and genomically informed treatments in metastatic and incurable lung cancers, they now improve cure rates. We use these in what we call the adjuvant setting. And I think they're quickly going to move into the neoadjuvant setting. And we're actually seeing more patients alive and cured. It's better for society. And sometimes the alternative therapies, they're not great value because they're just not going to work as well. And they can be very toxic. So we have, especially our workforce, the absolute concrete of our society, this sandwich generation that's raising one generation and supporting the older one, able to function and able to contribute. That is absolutely invaluable. We've actually showed in nickels and dimes with data that we can all take to our governments and say, listen, this has got value at every level, value in human lives, value in quality of life, but also value in taxpayers' dollars. And I think that makes it an an absolute no-brainer. I also think that we need to continue to invest in other things that we can do to actually identify more patients early and treat them for cure. So I suspect that Dr. Seipel might talk about some early access programs to get patients through the systems early. As we mentioned, there's this stereotype of, the old person with a strong tobacco history who often does have lung cancer, but that still remains not only in the public's mind, but sometimes in healthcare providers' mind. When a young person goes with a chronic cough, it's just like you, Ann, told us. You have asthma, you have a lingering cold, you have long COVID, you have, allergies, before they start to think, do I need to start to work this person out for diagnostics for a potential cancer? So sometimes these patients who are younger actually have a much more challenging time to get into the system and to be identified at a time when ideally they can actually have a curative intent therapy, usually surgery, which is the best chance for a cure. I also think we need to continue to work at looking at investing in screening programs. It's great we have screening programs rolling out across the country, but right now in provinces, they're limited to those who are 50 or 55 of age at minimum, who have a significant tobacco history. But like you said, Kevin, more than 1 in 5 of our patients have never used a tobacco product. So there's some really amazing research going on now about identifying other risk factors and exposures. Radon that might be coming up out of the ground as an odorless gas in your house. In Nova Scotia, we're doing research on asbestos in well water and looking at other ways of screening for lung cancer that may be more cost effective and more accessible than doing CAT scans, which may actually be able to lead to more diagnosis early when we can cure our patients. And then finally, investing in our excellent colleagues, for instance, Dr. David in interventional radiology. We need to be able to get tissue quickly, diagnosis quickly, and a rapid turnaround so we're able to provide the best standard of care for our patients. And so when we look at value in terms of life saves, dollar saves, the evidence is there, even in the advanced setting. But if we translate that into the curative intent setting, these are really the advances, like you mentioned. I was so excited to see that new data come out from the American Cancer Society. Projected 5-year overall survival for lung cancer, 27%. Now, I mean, that's nothing compared to some other cancers like breast cancer or prostate cancer, but that's almost double what 5-year survival was 20 years ago when I graduated from medical school. And I think we've made so many advances right across the board. We need to continue to strive to do that. You cannot argue about the value in those numbers, almost doubling the numbers of survivors at 5 years, many of whom will be long-term survivors.
So I think just to point, like I guess the question I think we struggle with both as advocates for our patients really is, we are heavily involved in HTA submissions, as you know, for a lot of what we think is very valuable therapies for our patients. And as we are beginning to understand, and Dr. Kasema said, that pie of unknown genomics is becoming more and more known. But the problem, I guess, I'm going to put you on the spot here. It's more of a tricky question for me. There are those rarer tumors that are lung cancers. I'm talking about the BRAFs, V600Es. I'm talking about some of the others for which we don't have those traditional phase 3 trials that gets easily accepted through. And yet these patients come to our clinics, right? And how do we explain to them, yes, that everywhere else in the world we can get certain drugs, but we can't get them here in Canada? I mean, how do those discussions sort of bear out in your office, like when you see these patients? And like I just would have a BRAF V680 patients in the emergency room, trying to desperately get something for that patient. But when I hear some of the arguments that we don't have all the data, so we won't fund it because it's not palatable for our system, how do you respond to that?
So, I mean, those are incredibly difficult conversations. And you recognize that right from the beginning, that this is something that I struggle with and you're going to struggle with as a patient, but make them aware. First of all, you can never make assumptions about patients' financial backgrounds. And so I always make sure that they have to be aware. If there is a Health Canada approved therapy, even if it's not funded, that they're aware, because some people are lucky enough that they can self-pay. But for most of those drugs, they just can't. As you know, Kevin, they're about, $10,000, $12,000, $13,000 a month, which is absolutely inaccessible for most people. We also face those conversations in the eastern provinces where sometimes patients are not even of the age of 65 to be part of the provincial drug plan. They may be self-employed and not have private drug insurance. So sometimes there's even funded drugs that they can't access because just even the copay of 20% sometimes may make them inaccessible. So we have these conversations every day. What I hope to do for those patients sometimes is to try to find them a trial. They're often healthier if they're younger and have a genomically actionable mutation. But really, it's to continue to advocate at every level. So in Nova Scotia, for instance, we have a take-home cancer drug fund where you can make one-of requests. But we also need to, at a broader level, continue to advocate to our health technology groups. And I think that they are starting to listen. I can't really speak so much for Ines, but outside of Quebec, in the rest of the country with CDA, they're starting to listen more about real world evidence. And they're starting to listen more about those rare molecular tumor types, and that we may not be able to get, a randomized phase 3 trial. But if we can, for instance, have a synthetic control arm from real world data that we've generated at a population level from our Canadian population, and showing how that differs from how patients are doing in jurisdictions where they do have access, I think they're starting to listen. I think we also have an onus on us as the advocacy groups to start to say, listen, CDA, will you look at this case again? You may have said no before, but will you listen again? We've got some new data, and sometimes that may not be the pharmaceutical company that's willing to take that file back, but we can do that. There can be provincial organizations. Cancer Care Ontario has actually taken some cases back to CDA for a reevaluation. And then also advocating to the actual pharmaceutical companies. And sometimes there can be some pretty creative solutions. For instance, can we do a phase 4 trial based on quality of life, or maybe extending the indication to an ECOG2 population to try to generate some data, but ultimately as a way to access therapy for our patients. One of my longest living ALK mutated patients, which is probably one of our best success stories in targeted therapy in lung cancer, because these patients are often living double digits of years with metastatic cancer. He only has access to his current line of therapy because he was patient number 100 out of 100 who went into a pharmaceutical sponsored phase 4 quality of life trial. Otherwise, he never would have gotten that drug. And this man has now been on the drug for years, living his best life. He's coaching hockey. He's seen his children off to Harvard and to university and graduating from high school and living his best life. So I really think that we can work together in partnerships with our pharmaceutical partners as well to really find solutions, because I think at the end of the day, they want success stories as well. But it's never stopping to advocate. And sometimes these patient stories are so much more compelling than me or you or Dr. Kassam getting up and spewing statistics. It just takes one story to really tug the heart of a politician where they're like, I hear you. I actually see this as an issue. How can we revise the way that healthcare is delivered in our jurisdiction to meet those needs?
So just out of full disclosure, we could probably talk for 3 hours just on that one subject, but we to be fair to other panelists, I'm gonna do my job as a moderator, and really we'll come back to that if there are any questions. But I think I'm gonna now segue to Dr. Saipel, who is a surgeon, and it's funny because when we talk about what is the oldest like oncology treatment, it is surgery. And all these wonderful treatments that are coming afterwards are more newer. But I do think surgery is an important. And actually, it's funny because when most patients come to see me, and even if it's stage 4, the question is, can I operate? Can I get a surgery? And it's stage 4, and I'm like, I don't know. I don't think it's the right time now. Yeah, I think that's Saipel, you're well positioned in 2 fronts, not only being as a surgeon, but also in Toronto being part of the rapid investigation group there who sees these patients way before we do. I just want to know some of the discussions that you have when you investigate these patients, and when you hear stories like Joanne's, where a young patient who's never really had a reason to think about having lung cancer before is being investigated for a nodule. Like, how do those discussions go when you find out, you have a more involved disease than we thought, and that maybe surgery is not the right time now?
Yeah, thank you, Kevin, for the question. So, most of the patients we see here with, the early stage lung cancer, they will come to see us. They found these either through screening programs or via incidental findings. So they're doing some X-rays for other reason. They had some abdominal pain, or they're doing a cardiac CT, and then they find the lung nodule. And then we do have a program here called Lung Ramp, Rapid Assessment Management Program, that as soon as we get it's a one number that any family doctor can call in and refer, and then there is a nurse navigator that will get that referral and will get that patient to be seen within a week by one of the 9 or let's say 9 surgeons or one interventional respirologist that we have here. And then we'll give a very rapid evaluation. Typically when we see someone with chest X-ray or a CT scan with a lung lesion, we'll request a PET scan if the imaging is suspicious, and then a biopsy. And the biopsy can be done either by a CT-guided biopsy, but we also have a very active interventional respirology team here that we do a lot of endobronchial biopsies as well with ultrasound. As you mentioned, most of the time these patients will have early stage lung cancer when that was incidental, but sometimes they can have more advanced with lymph node involvement, for example. And at that stage we need to really discuss with them that we need to involve more therapies as part of the treatment. As you said, they always are looking for surgery as the curative approach, but we try to explain to them that surgery is not necessarily out of question. We just need to do some treatment before. And more and more we're doing, as Dr. Snow mentioned, new adjuvant treatments with systemic therapy, especially immunotherapy. And the reason we do that is because even stage 1 lung cancer, the cure rate after surgery is not close to 100%. Like we still have recurrences, like it's about 70-80% cure rate for an early stage lung cancer. So can we get better on that number? And I think the results with some new adjuvant treatment for a more early stage are very, very promising along those lines.
And just as a disclosure, I did my fellowship at Princess Margaret, so I got to see the RAMP program up close, and I'm very admirable for what you guys do, because it really is something that accelerates the ability of patients to get their investigation. I think it's critical. I think it's always a question of time, right? And there are places like Dr. Snow said that there aren't screening programs. Luckily, Ontario does have it. British Columbia has it, but you guys are about the only ones. So we have patients who really, I don't know, I guess they've been having their lung cancer for X amount of time, and just it took time for them to get their diagnosis, right? So you're there, you're seeing the patient before you. The cancer looks like it's bordering on being quite advanced, but maybe, and then you have all these tests to do. How do you sort of coax the patients who come to see you, having probably this cancer X amount of time, and all they can think about is, if I wait a day more, that's the end? Like, how does that discussion happen?
Yeah, it's a good question, because sometimes they will come, they've been doing some investigations elsewhere. There was a trial of a biopsy that didn't yield like sufficient tissue and things, and then when you go and see them, has been already 3 months that they are being investigated, and they're very, very anxious. But based on all the discussions we had here, now knowing the details of the tumor is so important today that even if we need to spend a bit more time to make sure what is the tumor diagnosis, tumor profiling, and the proper staging. I think it's so important that will impact the treatment of these patients, that is worthwhile spending additional 2-3 weeks to get those results done, right? Rather than rushing into a treatment that is not the ideal one because of timing. So I think I try to reassure them that we're going to expedite things as much as possible now, but we need to get the results, ideal results. Just a little bit of a background, surgeons don't need to study as much as the medical oncologists these days, because things are changing so rapidly, and all the things that changed in surgery over the last 20 years has been mostly how we actually approach surgeries. We do a lot more minimally invasive surgeries today, and that includes VAT, video-assisted surgery, and robotic surgery. So I would say about 85% of all the lung cancer surgeries we do here at UHN are minimally invasive procedures. And that's really excellent for the patients because they stay in hospital just for a couple of days and they return to activities in a couple of weeks. And the other thing is there is very good new data showing that in the past, when you had even a small lung cancer, you would remove the whole lobe, like the whole lobe of the lung. And now there have been 2 very large randomized trials that show that just removing the segment where the tumor is provides the same results as removing the whole lobe. So also the loss of lung function is much less these days than used to be. So I think this is just to give a little bit an extra background where surgery have evolved over the last few years. And I also want to mention that we talked about surgery for stage 4, and this is something we never thought before, but it's coming back now. Especially, it's not like you're going to remove all the disease, but the patients get treated for stage 4. They have sometimes excellent results with systemic therapies, but then there is one site which is resistant with what you call like oligoprogression of the disease. And that's where surgeons are starting to become a little bit more involved as well for the more advanced cancers too. But there's some studies still going in this area.
Well, I think you've highlighted something that I probably should have asked from the beginning, which is really where we're at with surgery and some of the advances that are just improving the quality of life of patients. And thank you for that, Dr. Saipal. And actually that segues quite nicely to what I want to ask Dr. Raman. So just full disclosure, as most people know, there's a little dispute between some doctors and the government in Quebec, and our health minister confused radiologists and radiation oncologists. So I'm not going to do that with Dr. Raman and Dr. David. I promise you, I know what you guys do, but it's just we found that funny here in Quebec. So Dr. Raman, just touching on what Dr. Saipal said in terms of our understanding. I think there's one thing that we're understanding more and more with all these systemic therapies is really that lung cancer has become very, very complex. And I think you see patients for various reasons. I'm guessing patients who are not candidates for surgery for one, but also patients who are on systemic therapies and that maybe we need just a little bit boost with the radiation. For those who probably are not familiar with radiation, you want to give us a little bit of insight as to what you do?
Absolutely, Dr. Zhao. So, as radiation oncologists, again, same thing as what Dr. Saipal said, we have to learn more and more about the systemic therapies, more and more about the biomarkers, because what you do also kind of affects what we do as radiation oncologists. So just to give a bit of background, radiation oncology has also advanced in the last, couple of decades in terms of being able to be more precise, being able to reduce the number of treatment sessions. Typically, we used to treat with 20 or 30 sessions, and then nowadays we have moved to doing more stereotactic or precise radiation, where sometimes we can reduce the number of sessions to 5 or even 1 if it's appropriate. So radiation has changed and try to become more convenient. I think where it fits in with metastatic disease is a moving target. So I think there's a lot of interest in, you know, using surgery and or radiation treatment to supplement systemic therapy and to get better results with systemic therapy. So the two areas where we see patients, one is where patients may have oligometastatic disease. That means they have a limited number of spots. Um, and then the question is whether any radiation or surgery on top of systemic therapy can help, you know, prolong the mileage from the systemic therapy. And then the other area where we see patients commonly is where patients are on systemic therapy already. Most of their cancer is controlled, but for whatever reason, there's one or a few spots that are progressing. So this is called oligoprogression. And then the question is whether any local treatment can help. So this data is kind of an evolving space. So there are kind of trials that have been done, a couple trials in China that have shown that there is a benefit to adding some local treatment on top of systemic therapy with limited metastatic disease. These trials were done with the older TKIs and the older systemic therapy. So there remains some question as to whether these benefits will still translate with, you know, better systemic therapies now. But there was just a recent trial from the US, which actually looked at newest generation TKI and adding surgery or radiation to limited metastatic disease. And it showed that we can probably get some more mileage out of the systemic therapy. So there's a bit of an evolving space because in some centers, you know, it's kind of become standard of care to treat oligometastatic patients with local therapies, and in other places we're still waiting for the data to mature. So I think certainly would encourage all patients in this scenario to kind of discuss the benefits and risks and in terms of local treatment. But we're seeing these patients more and more, and I think it's going to become an important component of treatment going forward.
You know, so I'm a medical oncologist, so obviously I know the drugs I give more than anything else. But when I've been sort of digging into really what the additional value of other treatments like radiation has given, like, I mean, ultimately what we want to give our patients is best survival, best level of care. How do you give the best level of control with the best quality of life? And I think radiation adds a lot to that. I mean, in the last few years, from your perspective, like, how can you sort of verbalize how well we can sort of mesh all these treatments together with surgery or with the systemic treatments along with radiotherapy for ultimately trying to give patients the best survival?
Yeah, that's a great question. So I think, you know, it's something that's a bit hard to quantify in terms of what is the exact survival benefit because the data is still maturing. I think the most common scenario where we can quantify the benefit is in oligoprogressive patients. So, you know, patients who are on a TKI, you know, who are doing well, most of their disease is controlled, and for whatever reason, there's a few sites that don't respond. And in these cases, most often the next line of systemic therapy is typically more toxic and or doesn't work as well. And if radiation or surgery, you know, can be delivered with minimal toxicity, I think one very easily quantifiable benefit is the quality of life, right? So you're getting to stay on the same drug that doesn't have a lot of side effects. And if you can add some local treatment to get more mileage out of that drug, I think it's very easy for patients to kind of understand that. We still don't know, you know, is it going to make patients live longer? And we're hoping for the data to mature. But I think in terms of quality of life, there's often a clear upside to some local treatment at certain states.
Super, thanks. So I'm gonna, ask Dr. David, and obviously we don't get to often talk to our interventional radiologists outside. I need a biopsy and I need one today. But we've begun to sort of understand that there are things that we didn't think about before in terms of treating, and I think you're well placed in being able to, as a radiologist, as an interventional radiologist, talk about some of the things that you do, like cryoablation, which, for most patients is like, are you freezing my tumor? What is that? For those who don't know, like some of the additional therapies that we can offer, can you shed some light on some of the things that we're now discovering in interventional radiology?
So, what we offer is very much a needle-based approach. And you could see the evolution in lung mimicking what we started off 20 plus years ago in the liver in the setting of CRC and HCC, and even primary RCC. So, there's two spectrums that I see. It's the very early disease, like in situ adenocarcinoma, in situ kind of lesions, where it's kind of biopsy and treat. And that's more of me versus the surgeon. And then the very late spectrum where it's oligoprogression and me versus the rad onc. And really those are the two areas that I see patients, and you can see it's very much what mimics liver and RCC. So in RCC, we and the urologists primarily treat the T1A lesions now. And, it's kind of very much a location that predicates what goes to what. And we kind of are partners in that realm right now. And then in terms of, liver, it's us and the HPV surgeons for usually salvage, right? So, just like the thoracic surgeons are now going to a segment kind of approach, that's what the liver people have kind of started doing about 10 years back. And, basically they need to spare as much liver as possible. So they basically have gone to a, more metastectomy, remove segments or shell out the lesions individually versus taking out the entire lobe. And in that setting, you do get recurrences, but then we kind of go in and do the spot treatments for oligoprogression, only because we have a smaller footprint than the rad oncs. So, we aren't coming from an external beam. Our energy is being deposited centrally with a needle. So the energy deposition is slightly more precise, and the amount of normal tissue that we're preserving is perhaps a little bit greater. And so those are the kind of subsegments of patients that I'm going to see. In the salvage treatment, often it's patients who really can't get radiation because they have limited pulmonary function, underlying interstitial lung disease or COPD, those patients who have a significant risk of pneumonitis post-rad, so they perhaps would come to me. But and then my issue will be, a pneumothorax, and having to have long-term drainage and things like that. So there is no real perfect therapy in terms of minimally invasive options, but you really have to have a multidisciplinary team where you work well together, and each patient can have kind of a tailor-made approach or a tailor-made treatment plan. And it very much has mimicked what we have seen in the liver and in the kidney. And it's I'm sure, gonna follow that same evolution where you're gonna have these partnerships probably in the early area and in the late area, and in between you're going to rely on your medical oncologist for basically quelling the disease and also maintenance. So I think that's what's probably going to happen.
It's funny, you said about, okay, it's us versus surgeons, us versus radiation oncologists, and oftentimes in our tumor reports, it's always the surgeons versus the radiation oncologist. Now you have the interventional radiologist. So I guess the question really is now with all these options, and it's great. I think if there's anything that I've taken away from this in the last few years is really how many options we have for patients. Like, how do, in your setting, in your team, in your hospital, sort of come to an agreement like this is the best for the patient?
It's MCC rounds and it's discussion. And, IR has now become the fourth pillar in medical oncology, not just for treatment, but for palliation. So you're kind of part of you follow the patient from diagnosis right to the end. And, we believe in that longitudinal care model, and we participate in the MCC rounds, and we have good relationships with all of our colleagues in terms of the subspecialties. And it really isn't a turf battle. It's more, what is going to be the best outcome for our patients, and what's going to be give them the best quality of life, because that is one thing that all of these amazing systemic therapies are doing. They're living double-digit numbers, so they can't just live, with the cancer. They have to live well with it. And so what treatment is going to minimize the morbidity is always the forefront of our questions. And that's that partnership that we've kind of built is, I think, really the best thing for our patients. So we don't really compete. We try to collaborate.
That's well said. I couldn't say it better myself. I just have one little last question, and so I'm going to direct this to either Dr. Snow and Dr. Sam, and then I want Dr. Yuan to have the last word. There's a question that came up about, some of the advancements of NGS and where we are with liquid biopsies. Any thoughts?
So I think that liquid biopsies are going to have a lot of promise in the future. We're still refining the sensitivity and how to best use those. It's obviously very attractive because it's much easier to do a blood draw than to do a biopsy. And I think it will allow us to do a number of things, including looking for resistance mutations when patients have progression on an initial line of therapy, but also really novel ways to say how well is something working. So you start on a treatment or you've had a curative intent modality, can we still detect circulating tumor DNA? So I think there's a lot of promise. It's not fully prime time by any means quite yet, except for maybe looking for some resistance mutations in the blood right now to direct next lines of therapy. But I think it's really going to be very important in the future for diagnostics and also for prognostics.
And we won't talk about cost because that would be another completely different talk that would take 3 hours. So I want to really let this the last word with you, Anne. And I was, before we started, I was looking at your bio, which is phenomenal. From a patient who's decided to take a stand and give a voice to lung cancer, I find that almost amazing, beyond belief. And I do want to give you the last word about where we are in terms of some of the stuff we talked about, but just in general, your view now that you've seen it from the inside. What's your perspective as to where we're going?
Thank you. I think I have sort of two major points here. From advancements, especially with actionable mutations here, there are some really exciting aspects to targetable therapies. We're seeing a lot more orally available drugs that is being introduced in clinical trials in the market. All the things aside, quality of life, this helps us return to the workforce since we're not tethered to the IV pools all the time. But funding and access remains an issue. Some of us are lucky to have medical insurance through employment. OHIP and ODB certainly doesn't cover us for these drugs, at least in Ontario. And access through clinical trials could be problematic too. One of the things that we are prone to as lung cancer patients is brain mets. And some clinical trials have not gotten to the point where they would include patients with asymptomatic or resolvable brain met. So that's something we need to think about in the innovations, is also about funding and access to anyone below 65 for that matter. The other thing I want to talk about has to do with the continuum of prognosis. On one end, we have screening and trying to advocate for expansion of screening programs. 20% that you quoted for never smoker lung cancer is for the general population of everybody. It's just an aggregate. It gets higher when you drill down into these populations to women, for example. It's 50 to 90%, 90% in young Asian women, for example. So how do we stop making this a gender problem or race problem and actually tackle the issue at hand here? It's like you are of a certain demographic with higher risk factors, and therefore you are put into this bucket and qualify for low dose CT scan. So that's something to think about. When and how, we already have proof points from Taiwan, for example, and from US. When and how do we get there? The other thing is on the other side is better prognosis for advanced metastatic cancer. We talked about surgery, local treatment through radiation, through interventional radiation. I would certainly hope that more doctors would take on this philosophical approach when they discuss their disease with their patients, especially for us who could tolerate side effects more generally speaking. So this is where I want to sort of put all of us food for thought here. It's like on one end, screening, we need to do better. On the other hand, what do we do with what do we do with metastatic disease so that we have better outcomes?
Thank you so much for that. And I looking at the time we're at close, but I want to again thank everyone for participating. I want to thank Dr. Sam, Dr. Snow, Dr. Saipel, Dr. Raman, Dr. David, and of course, Yuan, for your incredible testimony here. I hope everyone really appreciated this session on lung cancer. It is Lung Cancer Awareness Month. I should have said that at the beginning as well. So please, hopefully this was something that's informed you and gave you new thoughts as to where we're going. And I think everything we said today can apply to any other cancer. So all we can do is just to strive to do better. So that is it for us. I'm going to throw it back to Cassandra for the next session.
Thank you so much. It was just fantastic to have so many different experts and specialists in one panel discussion. And it really reinforces that, collaboration is key. And Dr. David, I really loved what you said, that, it can't just be about living with the cancer. It has to be about living well. And how can our healthcare professionals come together as a team to make the best recommendations and offer the best options to their patients, and include the patient in that discussion certainly as well. So thank you very, very much to all of our clinical experts. And of course, Yuan, thank you very much for sharing your very insightful thoughts and experiences with us. And we will move into the next session momentarily. We'll see you there.